years that I've been working with that are level 4s. And NC Star is great, but it's 2 hours away in order for us to get there. So typically, our providers that use it when they just need a break. We're not able to utilize it in a crisis situation because it's usually full. The other thing is mobile crisis that we use. You call them and you tell them that the individual is autistic. Well, we deal with mental health issues. Yeah, I'm sorry. Or we have to get the guardian's permission first. So if the guardian says no, that you can't come out, that's correct. You know, we run into that.
One observation, my son's situation. Preventive services I talked about here as preventing crisis. And my son has received a number of those services after a number of crises. And there's a lot of other benefit to it, which needs to be recognized. Even if he had not had crises, I would have wanted those services provided to him because it's provided stability and a lot more confidence in his life, a lot more abilities. So it should not be forgotten.
I don't know that, and with that point, do we need to have a separate SCS definition, especially complicated circuits, which would allow for that in a non-crisis situation? You know what I mean? So it's more of a, I don't know that it needs to be separate.
Okay.
And that may speak to the name. What is it?
Right.
Right, Ellen?
Okay, you probably really remember the crisis I had when my wheelchair broke down. My wheelchair, I'm in an electric wheelchair usually, and my two front tires went out completely. So I couldn't move at all. And I was away from home. I had to call the mayor, figure it out, because it was 5 o'clock on Friday afternoon. I could not get in touch with anybody. And what is a person supposed to do like that?
So what I think what you're adding and want us to consider is that there are other crises, especially around physical disability issues.
Yes.
Okay.
There are a whole lot of other crises things that I can think of.
Okay. And then what you guys brought up earlier too is that NC Star works with adults but not children. So what kind of things can we do you think, to improve crisis services for children?
I have about 5 pages on this.
Any highlights?
Jerry is going to send us our 5 pages. Triple.
A lot of workforce development, and basically, again, it's the implementation of the service in an appropriate way. There's some system maturation issues, there's rate issues, there's authorization issues. You know what I mean?
Okay.
But basically, the ability to mimic if we start within the waiver.
Okay.
Now that involves that, since it's the back-to-back conversation. Financial and sustainability piece of it. Workforce issue, huge thing, connection to other systems.
Jerry, you have to talk louder. Steve, you're not here.
I'm sorry, I forget that you're back. I'm talking to Dave, not Holly. So, I don't know, Steve, what are all our, we've come up with this
You
list.
wrote them all
10
down there
topics.
from our alliance piece, right?
No, not the crisis stuff. That's a different conversation.
Okay.
Anyway. Where was I going with it?
What I picked up was the ability to mimic
I think
in
that's
the waiver.
That's good.
That.
Yeah, and then
And
financial
you have something in
sustainability.
the
Financial sustainability. Because just based on the current waiver rate as it is, it would be possible to mimic STAR.
I have a question. As a parent, I don't ever think I've ever been advised that there is a crisis plan. Like, I wouldn't even know what to do if it was a weekend and my son, needed, basically, I guess I'd have to call an ambulance or something, but I don't have anyone's like 20, there's nobody that I could think of that I would be able to contact maybe on a weekend.
And I think that goes back to the education, because anybody receiving services should have a first responder.
I can call, Autism Society and try to track someone down.
Do you have a plan? Oh, that's your plan.
So we have like we're on call.
But, I don't know, maybe, I have like a sticker that says, you know, for a fireman, there's autistic child. Maybe there could be some stickers that could be given to the people to put, to post like the number to call in an emergency.
Do you have a crisis plan attached to within your prison center plan?
What?
All prison center plans should have a crisis plan.
I'm sure well, I guess there's one in there, but I've never like had to look for it.
Yeah, but yeah, I think what you're raising is
I just kind of wanted something, you know, in an emergency situation,
yeah, who do you call?
who do you call?
Like a magnet, like.
Mom.
Just something, you know, just something that I can just stick up on the bulletin board or something, and say, call this number, an emergency. So,
I mean, actually, it's kind of weird, when you think about forms and stuff, sometimes we forget that, so you write a plan, and my assumption is that every day you don't read that plan.
no.
And, but in an emergency, that might be the first thing you go to, is to grab that. You might know where it's at, maybe not. But if on the top of it was, here's the phone number that you should call, you probably would have written it down somewhere. So that might,
Just something like a poison hotline
Right.
used to put up,
Yeah.
just something like that, so that if you're in crisis mode and you're freaking out, you can just look at some like bright red and white sticker and tell you what to do.
Anybody that has a child in that,
Anything.
those moments come a lot more often.
oh yeah, that's right. Chris?
Thank you. Well, I think that in the system, I think we're moving toward sort of a no wrong door idea, which kind of comes back to date myself before. One way, and I think we ought to think about this in terms of even crisis, that type of prevalence and training and knowledge across our entire system, you could call any one of those numbers and then get to, I'm not sure yet how to phase all that out, but the idea being that as a parent with a child, I may be calling, or I may be calling the hospital ER, or I may be calling my MCO, but, or maybe, so it's how is that then looped back into a, where it needs to be for the support system. So the idea is,
One thing, it's really important conversation in a lot of ways that what we don't want to do is encourage people to call 911 if that's not, because that often will wind up resulting in a worse outcome, which would be an emergency department, a place to go. So we want to make sure that we have, to the extent possible, that the right phone calls made to the right person that gets the support that you need then. We know we're not there yet, but it probably goes beyond just this conversation. It goes into a larger systemic issue about how do we get that information out. Ellen?
You've probably heard this from me before, but I was in crisis about 3 years ago. The only person I could call and really get help sleeping was Judy.
Okay.
But
So we're going to give Judy's number to everybody. in
no.
the
But that was the only person I could. I mean, I called Cardinal Innovations. I called. I mean, they gave me another number, and no one could calm me down.
Got it.
So I think you all need to think about how people really connect and how people really need somebody that they calm down with. Yeah, they trust.
Great. Thank you. Bob?
So, some of us participated in the Crisis Coalition, which is a great effort that the department is doing. It's really the broadest group of all types of people, from sheriff departments to prison people to, it does have more of a mental illness and SA focus than it does IDD, but for sure, there have been meetings that focused. There was one particularly that's focused on NC START and educating the communities and what that service is and how it works. But I happen to have a family member that recently had a crisis, and I guess the thing is, as a family member, you don't. Sometimes you don't see it coming as clearly as you hoped, and then it's there on you, and it moves from a things aren't quite right to quickly a crisis. And luckily, the situation that I had was a mental health related dual diagnosis situation, and was able to. I want to reinforce something Dave said. There is the department opened up and supported this Wake Brook. If you're familiar with that, it's across from Wake Med. And it is a setting whereby you can get an assessment, and they also have inpatient if that's needed. But anyway, it's designed to intervene before it's a crisis and you have to go to the ER. And that is really both for people with mental illness and substance use, but intellectual developmental disabilities that may have co-occurring disorders. That crisis, by definition, means it must be responsive. It must be available now. And so whether it's a MCO hotline or a provider of any type of services, we ought to be able to be responsive to that and escalate it commensurate with the level of urgency of the crisis. One other thing, since we're talking about innovations waiver services, is a concept that I have talked about for some number of years. Dave's had to listen to it a bit, but it is the idea of, sometimes we call it the lead agency. In mental health, we have designated CABA, critical access behavioral health agencies, right? And they are comprehensive, meaning they have medical, clinical, QI, QA, staff training, oversight. Our IDD system, in my opinion, has never developed that fully. And we aren't funded necessarily to do that, but we need to be moving towards some kind of a system of accountability, such that whether, I like the word navigator, I like the word principal accountable provider, that phrase. It's got to be something where people are assigned, if they're a regular service recipient, are assigned to some lead who's responsible and accountable for being responsive. And if they're not a regular service recipient, then you have a intermediate MCO, really, in our world, level of responsibility. But as we move forward, to be forward-thinking, we need to have a lead agency type designation. I use that phrase just as a descriptor, as functions that will be associated with this person, not particularly that phrase. So I would ask you to consider that as we move forward into our new world.
And that's sort of the intent of this, of this definition before. Like what Paul was saying, one big issue then comes to building up consistent operation.
Carrie, you said something?
It doesn't need to be a no, it was a question. It was a question to Sandy.
He said, I'm going to say this so low, Holly can't hear me.
Yes,
so
that's
she can't
right.
hear me.
Right, because it's really not.
It was all about Holly.
Sandy never practiced.
I'm putting that up there just a minute.
Okay.
All right.
So there's a few more questions. I mean, do we feel like the definition, and these are things you guys can think about later, but are there any specific tasks that we're missing? Are there things that NC STAR does that we're missing in here that needs to be included?
Do we want to make it the best practice model that we?
Right, do we want to make it the best practice model? That would make sense.
I think that'd be fabulous, and I still have to advocate for all the individuals not on the waiver, of course, and there'd be a huge gap. But for those who are on the waiver, yes, why not? Why wouldn't you do that? So that said, it is missing a lot, and we'll I'll take it back.
Okay, so we'll do it that way, and then, of course, we'll share all the information. Then there's some other miscellaneous information that's just kind of needed when the definitions go into CMS, and that's why some of these questions are here. Does the site have to be licensed or not? So we don't have to answer that now, but it could happen anywhere, so it wouldn't be a licensed place. The locations of services, we want it to be everywhere, I assume that we can. Did I miss anything, Liz?
Do you want to give them some context from where you came up with these questions?
So these questions came up from the
Small definitions group that we've been meeting every 2 weeks, past couple of months, just kind of review definitions to which ones we want to present first, to get your feedback, and we'll go back and do the tweaks you want us to do, and then we'll bring it back to you and see if this is.
And so some of the specific questions on here directly relate back to what we will have to answer CMS on.
right.
And
So that's
so that's kind of the context of what, not just, is what you're thinking about, but as we think about this in context of a waiver and the feds, this is the stuff you gotta answer.
Going back to the concept of annual budget, that some of these would be not service definitions, not guiding, but budgets and individualized budget. I noticed here on the last page it talks about that there was currently no limit other than $135,000 cost limit. Will there be something that's set aside that if a crisis occurs, then there is something that helps that budget, or does that come out of that person's total budget, and now I have to give up something else because I had a crisis?
So we'll talk about that. Yeah. So right now, and hopefully will be helpful information too. Right now, I just sent out yesterday, I believe, the last data request. I'm taking a step back from your actual question, but I sent out the last data request for budget information from the MCO, spending information, and Monica's going to kind of try to track that. Once we get that, we'll be able to more accurately look at our spending algorithms to look at what that's going to look like overall. But there is in the model, yes, there's an extreme circumstance, that's what they call it, but yes, and we also might want to think about whether or not we want some kind of like $5,000 for life emergency fund. I mean, I don't know, these are things to think about.
Is that model you asked for, the spending information you asked for, is that taking into account the lack of backup staffing? The fact that service was authorized but money wasn't actually spent because there was no backup staff?
It's just literally claims information.
Okay.
But we hadn't, so because we just are closing out, because we're on a state fiscal year and that's in July, and they're just kind of closing out their books, we need the completion exercise for that, because eventually we'll come back in the rate setting context. For those of you that saw that webinar from Burns, or from HSRI, I think we're going to do it again for the folks that couldn't make it. This feeds into that context of starting to really look at what our state-specific data looks like. So we're finishing the data collection. Are we done with this one, or what do you?
Okay, move on to the next one? No, one more?
Just one request. Under exclusions, I guess the specialized consultation services definition is included by reference. To fully understand this, could you send that out to us?
So send down specialized consultation. That's cool.
I want to know what it is.
No, I do too.
So if we look at the SCS definition and we look at the behavioral consult piece of this one, and then we look at the CMS mandate around autism treatment, can we do them both? Can you put that in the waiver and then there's a,
Can we put what in the waiver? I'm
I
sorry.
mean, specialized consultative service and behavioral consult is very much near theoretically, kind of a intervention treatment methodology. Good, non-clinical piece of it. How does that impact that or not?
We're not prepared to answer that question today.
No, but I mean, I think that if that's the question, we need to think about it.
I've got a question.
And we just
saw it under the sections with the questions, is, it's talking about intensity of service, and it says dash individual group conference invoice extensive. Is there a concept that you could have a crisis plan that would treat a group, let's say in a group home, or, so that it's not an individual service, that it might be a group service?
Oh, this might be.
I'm not understanding that sort of question.
So that's, again, it goes back to how what box you check on the CMS waiver. So if it's individual, if it's group, if you're going to a conference, that kind of stuff. So, theoretically, yeah, you could have a.
But with crisis?
I have no idea what it looks like if that's what you're asking.
Yeah, because sometimes the crisis could be the way individuals interact in their group home or their.
But here's a question.
I just had never thought of it until I saw that.
But maybe a connection to that would be some of the issue with workforce and availability of psychologists within MCO networks. A big issue is that a psychologist can't necessarily train staff and have ongoing supervision and monitoring there with another provider, because they don't have that supervision reach technically. So maybe, that's what that is. That's a big issue. That one needs to get written down, Holly. The psychologist's ability to provide clinical supervision.
But if you're asking if there's a crisis group, if you will,
Yeah,
that's not.
could the service be provided to a group?
But opposed in theory, it could be, but I don't know if that's
How would we write, not writing it that way?
Right.
Okay.
But part of what you do under the behavioral consult piece of crisis is train a group of staff on a behavior plan.
Yeah, and I'm thinking it's.
You're thinking like all of us are in crisis and Dave's gonna
Or
come.
like
calm us all down.
consumer A is in crisis because consumer C and D were doing something else, and so you sort of had to address the dynamic of that household, group home household.
And it's not just group homes. There are families with more than one individual on the waiver, and that does happen in those families where one of the individuals goes into a crisis, which then affects the other individuals. So it's not just group homes.
Anyway.
Okay.
So any other comments or questions on respite before we go on to residential supports?
Okay, with the crisis, residential support, of course, the names will table that to the end. And then down to what do you see is working and not working in residential support?
Yes, ma'am.
I provide mostly residential supports with the agency that I work with, and I think the biggest thing that we've had is the turnover rate of providers for our 3s and 4s because of the no respite situation.
So because the
lack of
providers
our
can't
AFLs
access
not getting a break.
Okay.
I hear that a lot.
Yeah, for instance, I had a 4, and they would get one, maybe every 6 months she would go to NC Start for 3 or 4 days. And they gave her up because it was just too much.
Okay. So thinking about bringing that back into the rest group.
And then we have some individuals that are TBI, so if they don't have that IDD diagnosis, they don't qualify for NC Start. So we don't have anything.
So people with TBI on innovations waiver.
Yeah.
And I guess that sort of touched on change, what can be changed to enhance the options available to individuals who choose where they live, and yet as independently as possible. Do you want to give comments later, or?
I think I'm all right. I'm gonna try and. I'm looking flashing gang signs to Bob over here. Provider council issue. That side.
Go ahead, I have several questions.
Go ahead.
At some point, Now she's trying to figure out where it's best to ask them. But the, in the service definition on the first page, it talks about 3/4 from the bottom, the residential support daily rate, including payments for relief staff. So that kind of gets at, in the group home, we're offering a family living setting. So that's a good thing. That helps resolve, if implemented, some of the issues.
Well, they currently have that, but the thing about it is though, that the relief staff has to go in their own home. So for our
Yes.
AFLs, they have to leave their home in order to get a break.
Yeah, I got you. Same.
So,
Yeah, old issues still no
yeah.
solution. Yeah, whether or not, that's a whole other issue. I don't have something for that. But I do have, there was lots of questions when this first came out as far as the number of beds. The 3-bed versus the 4-bed. Who determined 3-bed was best? What's the data that says
It was
that?
determined by CMS in the 05 or 08 waiver. It was determined that CMS basically said that this is where we're going. I know that currently we are trying to put into the waiver to get it to 4 beds, which I think everyone has agreed that is a better model. Mean girls always say that one's always left out. Who's the mean girls?
Yeah, I just didn't sit, I'm aware of that, and I just did not see that reflected in this document. And this document is presented as though it's 3, and by gosh, it's 3. So
Gotcha.
let's have a question that says
So 4 beds?
to 4 beds is the recommendation.
Yeah.
That ought to be, to me, it ought to be a recommendation. I don't think the feds would enforce the 3-bed, but that's up to you guys to decide. But I think states do have some latitude, more latitude than now than they did when Sandy mentioned that that's where the guidance was.
At that time, we were looking at bed size as community characteristics versus characteristics, which I think is why we should not have a problem going to the 4-bed.
So if you develop a new 4-bed home, you would obviously meet all the community characteristics that are.
If you develop a home, then
That's
all
right.
the community characteristics.
Okay. So, was that it? That sounded like you had a lot more going on there.
Well, just going to the residential supports, when, and moving to individual budgets, the residential supports and individual budgets are complex. And I've been involved in for some number of years, and the, I guess the rate methodology for that, is that going to be done? The CIS and the relationship between the individual budgets and all the input factors that affect the individual budget beyond the CIS, and what are the functions that you want performed, and then determining what first, and then determining what it costs to provide
Are you
that.
asking what the algorithm for the individual
That-
budget
that's
is,
right.
or for the
Yes.
service?
For the,
So
for the individual budgets.
So the
and-
individual budget is yet to be determined.
And then, as it moves forward into, especially group settings, it gets more complex with any kind of group setting that you do, and it's going to take some work to do that. And I want to be sure that we talk about that before we decide firmly on what, and then say, well, we can't really fund that. Let's decide to some extent what we can fund, what the model is that we think we can afford, what, you know what I'm saying? We don't want to get stuck. We don't want to get stuck with having declared a service definition and then decide we can't. So the rate methodology that goes with all these pieces needs to be done concurrently to some extent. Even though you'll do, after you send it to CMS and they approve it and everything's wonderful, you'll do your last official rate methodology that you've got to put in
Right.
Appendix D or whatever.
And we'd like to
Yes.
maybe bring somebody in closer. So we have not, like I said, we have not yet determined what the algorithm is going to look like. It will be be our decision to kind of make, but to that point, I would think that once we get the rest of the data in from the claims data, and we start looking at what our spending patterns are and stuff, as we move closer to that in one of these meetings, probably would be a good idea to have somebody from rate setting in one of these meetings. No? Oh.
Yeah.
So I was thinking that, I think that, yeah, overall, be a good conversation.
I have a question about letters providing authorization for the opening of new group homes. It was my understanding that there has been, Cardinal and the other have said there's no openings for new group homes to come into an existence. And that's kind of been the way for a while, and it doesn't seem like there's some sort of any formula. If there's openings in group homes that exist, even if, say, those group homes are not preferable to others that might be available should they get a letter, the definitions all seem to emphasize personal choice and latitude and saying where you want to live. And there might be a lot of subpar group homes that have availability, but if somebody wants to open a group home that is more better suited and would be more beneficial, shouldn't they be permitted to open it and let the people choose where they want to live?
So that goes back to the business decision of the LMUMCO. Anybody can open a business, but they can't necessarily be a contracted network provider. And, I'm hoping that if there's anything that's subpar, it's being reported back to the MCO when they're doing appropriate monitoring, because that's part of their requirements as well. The basic choice is just a choice of two providers. And the B waiver, that's what it does, is it closes our provider network so that we don't have to take any willing provider. And that's supposed to be part of how the MCOs achieve their cost savings, because they've started controlling their provider network and making sure they're only choosing good providers and doing things that are cost effective. And it's all part of the theory behind the B. Because we're talking about the C waiver here, but the C waiver rolls up into the B. So all of these folks are also covered by the B waiver. So the short answer to your question is no.
But you raise a very important question about system design. And especially if we're headed toward a system of much more individualized supports and services. And I think we probably want to have a larger conversation. I think Mary and her members will want to be a part of that conversation about.
But by definition,
we don't.
You do not have to take
That's
any
like
provider.
probably a very critical choice that, you're basically saying, look, you can choose amongst, and to be honest, the vast majority are for-profit group homes, which sometimes have a different level of care. And I'm not saying like the quality than maybe a nonprofit. Maybe someone would rather go to a nonprofit, but they don't ever have that opportunity because the nonprofit doesn't get an authorization to
But so
have
I think that's what the focus, though, I think what you're saying, rather than whether or not a new provider would come in, what you're really thinking, what I'm really hearing you say is you might want to think in your definition about what you want that to look like, whatever it is, an existing provider, a new provider, or what is it you want the provider to look like?
Well, there's no, it's
How do you
not
define
specifically.
subpar versus?
Well, I just think that sometimes a nonprofit is better suited than a for-profit group home.
Sometimes they're not.
And sometimes they're not. But the thing is, the market is closed, basically, to those that are already in the market. And so.
You do an annual gap analysis to ensure there is a coverage and choice of provider. And if there isn't, then the MCOs need to do that network development to get that missing piece in.
I want to jump in because I think maybe what you're asking actually is going to have to be fleshed out, because in the home and community-based standard side of where we're headed. This is the characteristics issue and the federal rule. There's a requirement that people have the ability to choose where they live and who they live with.
Sure.
Which is going to clash with
Yep.
some of these issues. So we're going to have to address it.
Yep.
I'm not so sure right now we can in this setting, but what I'm going to suggest is Holly's going to write something over there to say we have to come back to talk about that issue.
Because it did come up in our last time on that committee too, and it did come up last week from a parent. And we, as the Downtown Society, are approached on a very frequent basis from groups of parents who want to start their own programs. And so that was that concept. Well, that's great, but the network's closed, you have all these definitions we're going to have to work with, you know what I mean? So we are trying to educate, as an education group, parents about all of those things, but it's not getting reached. So anyway, I mean, it's Anna.
There are significant barriers to entry due to the way the system's designed. Even if you were to open it up, because on an annual basis and do it on an annual review, setting up a house like that's complicated.
I am going to suggest that we kind of take this notion and make this a different conversation, because it's complex. It has a whole bunch of moving parts that we're going to have to address in terms of what we're working on.
If I could say, I represent for-profit and not-for-profit providers. Some are better than others, both for-profit and not-for-profit.
You never said that about your members ever before. I'm sorry.
I mean, that's the way it is. Everybody, every part of the workforce, all of us have good, some that are better than others. But I don't think that the factor necessarily is, critical factor is necessarily that they're for-profit. They can still have very high standards and do very good services as a for-profit.
Hopefully, if we have an adequate network monitoring strategy, they all should have excellent standards.
The thing that Dave did mention, that another work group's looked with HCBS Home and Community Wage standards, is the concept of informed choice and what options do you have? Do you have the option of choosing only good options, or are there bad options? If there's no other option that you have to take? That came up in another meeting. So similar to what you're saying there, that I think the department is trying to consider and listen to stakeholders on that.
Well, I mean, not for nothing, my mother never would have let me got married if you weren't allowed to choose the bad option.
Most of us would have never gotten married.
Right, yeah, that may have been a showstopper.
So back to our document. Oh, really? And marriage was mentioned in the very first service definition we reviewed, the shared living service definition. How would that not just blend into this?
It could. So this is the existing definition, so it definitely could.
Which service definition?
Shared living.
Shared living.
Which is good, and I applaud shared living, but just to me, it's a residential, it is a residential option.
Right.
Is it licensed or not?
So I guess that leads to a question of if we didn't get all the service definitions and you're working on some other service, what are the other service definitions you're working on? And when will the soonest draft be available?
I think what they've decided to do, and correct me if I'm wrong, Kenneth, but they switched it up with their service definition committee, and they've gone the opposite way. You're getting them all new. Nobody's working on them right now. You're getting them right straight as they are now. Not new, I suppose new is the wrong word. You're getting them instant. We'll see what you will think of it, and then we'll take it. Then it'll go to the committee to kind of take
So
your
you guys are kind of
suggestions
shaping
into-
how it goes versus on the other end. And then, I don't think you were here last meeting,
I
but you
wasn't,
guys
I'm
went
sorry.
over assistive technology, integrated supports, supported living. So those ones are being flushed out, and they're getting input from their stakeholders locally, and then that's going to come back to, I think, November 21st.
Thank you.
So, yeah. So nobody's working on any of them anymore. It'd be all your waiver definitions, but they're just going back and work first. Does that make
And
sense?
this information will go back to be included, and then these will come back to you guys.
So making a plug for how much the folks at DMA and DMH have been listening to what people have been saying. I think they heard folks, in particular the last one, and went back to the work groups. And this really is a pretty significant shift in the way of doing business, which I think is a great item. Applaud their recommendations. I wish you would say we thought about that ahead of time, and I would have loved to take credit for that. But great idea. I'm just joking about what you guys, wonderful idea coming from that committee, because that really is paying attention to what people are saying.
And then, of course, send us the feedback that you guys think of later and your 5 pages and everything, and then you can incorporate that, because it is, a lot of information at once.
Again, November 7th, please, your comments, so that when we meet, we can address all the comments that we receive.
Are there other comments right now on residential supports?
Is there anything you guys think we should take out or we need to add? Anything better?
Is the current definition clear about other relatives being able to provide residential supports, like aunts, uncles, cousins? You know, this idea that we're really talking about long-term services and supports, and mom and dad aren't the be-all, end-all. So brothers, sisters, aunts, uncles, cousins, because to families, I think that idea of, well, we're going to get together and start a group home, that kind of situation generally involves some other relative being what the group home owner, provider. So Katie's cousin and her husband would start the group home. Katie would be the first resident, and then my friend's daughter would come in to the group home when they were ready, and you know what I mean?
Right, no, that makes sense.
So somehow all relatives, you know, we're not the evil enemy.
No, I think that from the way that we look at it, it's the same as the other services, as long as they're not the guardian and as long as they're not.
Well, but the cousin could be the guardian as long as you're not paid to be the guardian. You can provide waiver services. That's what the guardianship statute reads right now.
Okay.
Any other comments? Any other just general public comments?
So, we're still going at a pretty quick pace. November 7th, next week. 2 weeks, sorry.
No, you're right. Good grief.
It's only going to get more intense for us in terms of that time frame, and a lot of, when we get into the individual budget stuff, it's going to get there. So the next webinar is when?
November, I can't remember when.
November, so it went out, so if you haven't had a chance to do it, I would encourage you to get on that webinar, because it's really important as we have our conversations that everybody's sort of at least has a background on it.
How long does that last?
An hour? Is an hour right? Yeah, I think it's an hour.
It's better to participate than read the PowerPoint.
Yes.
There's more discussion.
Yes.
Especially if that's what people already saw.
So
And here folks are saying, can we send the
follow
link?
up on this, or are we following up on the last one you had?
We sent out the slides.
I didn't get them.
Do we know?
We can get them to you. They're public, I mean, but we sent out everybody, and that might have been before we added you to the listserv, I'm sure. But
Okay.
everybody's gotten the slides otherwise, I think. So you've gotten the slides, but I didn't quite hear you. Were you saying, because you heard it and it was good to listen to?
Oh, yeah, I thought it was great, yeah. I'm very curious to know what your next set of data may show. That to me was fascinating, just how random we are.
We really are.
We are
Spending
random.
in the state's wacky.
Was December 7th the webinar, or is December 7th the meeting here in this?
So our next meetings are at the bottom there, the 21st, the 5th, and the 19th. The next one's at the Clark Building, which is right there.
Right. And the topic of discussion is?
For which thing? I'm so sorry.
November
What's
7th,
on our
next week.
agenda? The next meeting? I don't think, what do you want to hear?
I think we're working on the agenda yet.
There'll be a few more service definitions, but in addition to that,
So
anything?
we'll be reviewing past definitions, or are we going on with
We'll go on to more.
more? Okay.
So just so I'm clear, we meet here next week, but you want us to get us our feedback on the current definitions we just went over today to you probably in writing before that meeting, is that right?
No, next week is Yeah, but not before the next
But
meeting.
it doesn't have to be, just on the.
Yeah.
On these, just on these three that we went today, not the ones from last time.
Maybe
Right.
it was.
Unless you have some from last time, since you can't.
Oh, that's a good idea.
No, we're not, we're not discussing this.
I know.
The date coincides with.
Okay, let's get back to where we, one person at a time, sorry.
You had said about that we discussed like more people getting authorization to do residential services. Would that be something that would be on the agenda soon or way down the line?
I think we're probably going to want to hold off for a couple of weeks, a couple of meetings before we do that. We'll make sure that we announce that really loudly for you though, because we have these parallel tracks going on around that conversation. They'll have to come back in here, but we will have it here. All right. So, thank you all for showing up on Halloween. Thank you for participating in our costume and effort. And have a great weekend. Thank you. And we got out. It is 3:30, not 10 to 4, so that's good.